warm welcome to the next episode of the IBD Essentials. And today it's a really, really great pleasure to talk to Thomas Rösch from the University of Hamburg. You know Thomas probably very well. He is one of the most famous endoscopists in Germany. And Thomas started a lot of activities in Germany and also outside of Germany with podcasts. I think this is, and I will ask him a little bit later about this. I think this was probably also driven by the COVID pandemic, and Thomas is very successful. He created the Endoscopy Essentials, so I had the pleasure to be one of his guests when he was doing this, and he's still continuing to do this. And for me, it was amazing that so many people got excited about this interesting thing. So today we planned to talk a little bit about artificial intelligence in IBD, perhaps even in medicine. And I think especially in endoscopy, this is highly relevant. But Thomas, before we really go and start, I really would like to just briefly know, why did you do the Endoscopy Essentials? Why did you start this, and how is your experience?
Well, the thing is, I think the whole online business, as you said, started with COVID. Although I did with a friend in Italy, Alessandro Repici, I started an online thing, and the planning started before COVID came about. And the mere reason was the budgets of the physical meetings. You know, we're doing EndoClub and other meetings, so the budget went up and went up and went up. And I thought we must think about something alternative, which is cheaper, of course, and reaches more people. And then COVID came, and we did these online meetings. But when COVID waned, there's still a lot going on. But what we did is we mostly put the online thing, not one-to-one, but similar to the physical thing, one-to-one to the online world. And with physical meetings coming back and people wanting to meet each other, the question is, will that survive in the same format? Or what's the best online format? And then somebody said it was funny, and I did a German thing. Wouldn't you like to do a podcast? And embarrassingly enough, I didn't fully know what that was. So I was very enthusiastic and said, yeah, let's do that Thursday morning, 7 a.m. And then they said, chill, it's recorded. So we might release it at 7 a.m., but we can record it before, et cetera, et cetera. And I found out that's fun. So then I decided to do something focused on endoscopy in English on a global scale, taking all the experience I had with online, et cetera. And here we are. Branching out into IBD. Yeah. So I'm very happy about that.
Yeah, I'm very grateful to you that you really helped and advised a lot, because your experience, I think, is tremendous. But let's switch gears and move to AI. And I think artificial intelligence has now taken over in our daily lives. It's not something which is very special for medicine. But I would like to focus a little bit on the medical part. And as you know, I think it is very important in several fields. So stick a little bit to IBD. And first of all, I would like to get your idea about artificial intelligence for endoscopy and evaluating endoscopy, because you as endoscopist and working a lot with different companies who have now the modern tools to use AI, so we know the different systems that will help us. I would just like to get your idea, because like 10 years ago, we were discussing how we can detect polyps. Will artificial intelligence help us? And at this point of time, you said sometimes if you're really good, we need to find the needle in the haystack, and perhaps this can help, but for the regular polyp, it will not help at all. So has it changed a little bit? Do you have a different opinion? And what are your views on this now?
Yes and no. I'm not a digital native, obviously. The thing is that I disagree with you that AI is in our lives. I'm afraid it's not. And I would like to have much more beside looking for small polyps. But the polyp thing is interesting in several ways. I think AI could benefit. First of all, The question is, when you develop something like that, how do you do it? And at least with a scientific mind, I'm not an AI engineer, you would think for a test to be developed, whatever it is, you need a good gold standard, which in AI is called ground truth, but it's the same thing. So with the small polyps, there were several softwares developed on a very limited basis, right? So, and then it turned out, of course, in this databases, they had mostly small polyps. And so the first softwares were for the small polyps, so people did find more polyps, not necessarily the flat ones. You were seeing deficiencies in the systems. And it's also interesting, all first studies were positive. In the first 3 years, we did an analysis, 100% were positive. And all of a sudden, with more, by the way, more Western studies, the positivity rate of AI studies has gone down to 50%. And there was even a recent study, which was the third or fourth in a series, saying when you introduce AI, you get worse because you get lazy. So it's interesting to learn, A, a good gold standard, B, to develop it further, and C, implementation, and also D, accept setbacks. Because there's the initial enthusiasm, and then you realize there are the limitations. But I think that AI will be there anyway. But what we have to do is also to think, where will this go? So back to the small polyp problem. There was a big recent paper saying the detection rate of adenomas levels off at like 35%. Above that, you don't have any benefit. So when you already have 50, why have an AI? So this is the type of outcome thoughts you have to make. Rather train the people under 30 or under 26, which was the level of absolute effect, et cetera, et cetera. So I think the other specialties like IBD could learn a lot from the development curve, up and down, and hopefully up again.
I think you really touched upon a lot of very important points. I think something which is very important is the implementation and also the drawbacks or setbacks you will suffer, and to be more open and really to look out of the box. So everything you really mentioned there is very important. And we know, for instance, that if you have an investigator like you, very experienced, and the AI will tell you, oh, this may be a polyp or not, and it takes like 3 or more time than it used to take before. So for you, probably not that relevant. We did it.
I'm not sure. The worst guys for ADR are elderly men, by the way, but anyway.
But we tested it, for instance, with our fellows who were getting in training, so not that experienced, and they were not really unhappy about this. But I would also like to move to IBD. So we have now recently just used a prototype to really assess the inflammation in patients with IBD. And this is where if we talk about IBD and AI, one of the major topics to really make our work a little bit more productive. You are aware, we have a lot of studies. And initially, there was reading of the endoscopy just by the investigator, and there is a huge variance even between different investigators. So the gold standard in our clinical trials is now central reading. So there are videos, and these videos are sent to certain experts, and they do the 10,000 colonoscopies of one trial. Sometimes they are overwhelmed with the work, so it takes a long time to get the results. And there are also always technical issues with the videos and so on. And this could be probably significantly improved, just having AI-centered reading. And there have been studies at the huge congresses, DDW, UEG, in the past 2 or 3 years, that when you do it in a standardized setting, it's better than the central reading. So do you have any thoughts on this? And probably there are similar data also with polyps.
Honestly, I find this area much more interesting because it's methodologically more difficult. A polyp is a polyp, and then it's an adenoma or sessile serrated or whatever. But inflammation assessment macroscopically is a very subjective thing. So my first question back would be, what's the ground truth or gold standard? Is it, Is it a composite of several endoscopists, or is it histology, which can be quite different? So as an intermediate step, and I really would like to discuss this idea with you, what AI is probably probably able to do very perfectly is to imitate one person. So the Axel Dickner sitting there can be probably imitated by the Axel Dickner's AI avatar.
Yep.
So why not creating an expert, database, 15 people, and then they score the videos like you would do, and then, elevate this process. But whether there's an independent ground truth, I don't know how you will solve that.
This really shows that you're a smart person, because this is exactly what is the problem. The problem is we have different scoring systems. We even do not know what are the best scoring systems. So make it simple. I think everybody knows the Mayo score, and there are different scores.
Which is only partially endoscopic.
Yeah, and different scores for the endoscopy we use. And there is significant overlap, and even experts are sometimes not that sure what is a Mayo 1 or Mayo 2 or Mayo 2 to Mayo 3, because it's not really made in stone. And this is the most simple score. We have several other scores. And for Crohn's disease, this is discontinuously spread throughout the small and large bowel. We have scores. One of them is called the simple endoscopic score. And it's so simple that even when an expert needs to do it, you need a paper because you need to look up what you need to score. And this probably can be standardized. And even if you make then the same mistakes for all the 1,000 patients, then it's reliable, and it's more reliable than having 10 or 1,000 different investigators. What I really like about this is something which would go beyond. My example is that think about a dog, think about a cat. They can see something which we cannot see. So they have more capacity to find something, and we look at what we know. We look at ulcerations, at the blood vessels, at the mucosal level. What would be if we would start from the scratch new, have patients with clinical data, have patients just with endoscopy films, and you do artificial intelligence, a software, do something and identify those things that would be relevant, and then create a new score, and then use this score. One very good example, which this brought me into the field, it is possible to make a retina scan and tell you your blood glucose levels. You can tell about the hemoglobin A1C level just having the retina scan. When I read this paper in Nature, I thought, it's ridiculous. How can this work? But it's really reliable. So would it be possible to do an endoscopy?
Yes, yeah, of course, but with the retina thing, it's a clear gold standard. Blood glucose picture. I think that's a classic for AI. In IBD, you have to tell what the gold standard is. Is it a certain clinical picture? Yeah, then there might be patients with a terrible colon without therapy, of course, so the influence of therapy, and you just look at the clinical picture. You probably would have to have a follow-up, like a stable patient over, 6 months, but that's a fascinating idea. So don't care about the degree of inflammation, care about the patient.
But this is exactly, we have a very holistic picture of our patients. So it's not only the endoscopy, and back to my times when I was young, when I was trained, my first boss told me, there is no correlation between the endoscopy finding and the clinical symptoms of the patient. It doesn't make sense even to have frequent endoscopies because there is no correlation. Now we have learned there are certain correlations. And as you mentioned, we look at clinical data, we look at transmural data, so we do intestinal ultrasound or an MRI, we look at extraintestinal manifestations, we look at the histology, and this makes a picture of an IBD patient. And one of our major problems is that we probably lump a lot of different diseases in 2 or 3 entities. So we have Crohn's disease, we have ulcerative colitis, and we have the indeterminate colitis. But I think also you, as a very smart person, will not be able to explain to me why a Crohn's disease patient will have fistula and the other will have no fistula but strictures and will develop stenosis, and one has small bowel involvement, one has upper bowel involvement, one has lower bowel involvement, some have continuous inflammation, some have more limited inflammation. So probably these are even 10 different diseases just lumped together because of histological and some mucosal pictures. And this, I hope, can be also, we can create more phenotypes, we can develop more individualized treatments and management of the patient. And this becomes now relevant because we have left the area where we only had steroids. We have now 20, 30 different medications. And if you just look at always the same things, they will always have probably something like the same outcome. And some of these outcomes are really relevant.
But still, I'm sorry to insist on that. But what you have to decide as a clinician, what do you want to know? Do I want to really know just the degree of inflammation by consensus of 3 people? Or is my outcome, my ground truth, a patient follow-up after 6 months, whether the patient does well? And what do I have? Ultrasound and endoscopy and so on and so on. I don't think you will get around defining this. And then you can have your AI work on that.
Yeah, and I think this should be the ultimate goal. And personally, I believe this will not work with endoscopy alone. So what we would like, and this is one of our major problems, now you have a patient. You would be my patient. I diagnose ulcerative colitis. And as you're in a certain age, you have no comorbidities. I can tell my patients for the first line, very simple, you get 5-ASA, but then it doesn't work. You are steroid dependent. And then I have 20 different treatment options. And sometimes I tell them I can throw dice because all can work and all cannot work. So it would be extremely helpful if you would have some tools suggesting you start with this drug because you have the highest likelihood that it will work and you will have no side effects. And when you fail something and I need to switch, again, the same story. And this is something which should be the ultimate goal, helping you to choose the best therapies. Even if we make the first diagnosis, we cannot predict if you would have a very mild disease course or if you would have a very severe disease course. So I started on a project with just getting data from a huge clinical trial. And there, this is perfect because you have the patient-reported outcomes. You have all the lab tests like calprotectin, CRP, you have the endoscopy, you have the histology. And I gave it to machine learning people and asked them, without knowing anything, just take those patients who have the mildest disease course and they will not need any real treatment, and those who are not responding to anything, so they get everything and nothing improves. This is probably a major difference. And then have some patients who have a severe disease responding perfectly. Are there any difference in the profiles of these patients? And this could be clinical parameters, lab tests, this could be the endoscopy, this could be number of neutrophils in the mucosa and the histology. And I think this is beyond our capacity.
Absolutely.
Intuitive. So this is something where I see something.
I couldn't agree more, but the conclusion when I listen to you is the advice: don't waste your time with just inflammation scoring on the endoscopic picture. Take the big picture, take a relevant outcome, give all the data into the system, and off you go, right?
Yeah. No, this is something I think for the future, but something we can start immediately. Just going back to our clinics, looking at the radiologist. So if you have a patient with a lung cancer, the machine tells you there are 32 metastases from this side, and you make the follow-up, and then you say, oh, you have only 15, so it worked nicely, and it's done immediately. In our clinical trials, we have now endoscopies at the start, it's month 3, sometimes month 6, a year after, and you have a lot of data, and this is done by individuals and central readers, and I think this is also something which could be standardized. We are discussing this for quite a while, but it's also interesting. If you do it in clinical trials, you know the very important people are EMA and FDA, and they are currently not really accepting this because these trials are typically run by individual pharmaceutical companies, and they come up, there may be a bias in it. So we are currently trying to build a consortium to bring data from different studies together and to identify tools to this. But again, you as a really practical person, there is a lot of different issues behind it. You have different endoscopes, you have different machines. You may, in a trial, have an update from the older series to the newest series, and everything that
It's not a big problem. So it's just the number of data you need. But if the gold standard, again, the gold standard in endoscopy is the subjective impression of an endoscopist. This is not a very good gold standard, but you can imitate. As I said before, you can say, this is Axel. Axel would say 1,000 pictures. He doesn't have to work a minute. He just puts it into the computer. That's Axel's opinion. And then you have, I don't know, Bruce Sand's opinion and others. And then you put it together. So you spare all this huge amount of time of you looking at those silly videos, right?
Yeah. So, no, I think this is something which is really perfect. And if you use this, going also back to the clinics, because we now test some of these prototypes in our hospital, all my senior people and myself, we say, we can do it in the same way. But our trainees are really, really happy. So they get, this is a Mayo 1, this is a Mayo 2, and it makes the procedure a little bit longer. But for training purposes, I believe this is, for instance, something which is very good.
Which is another aspect. So, yeah, especially, and I think, again, IBD is more difficult than polyps for the recognition and diagnosis and classification.
This was probably a little bit now about the technical issues. For the end of this podcast, I would just get your idea and your opinion on other uses of AI. So what I personally was also really impressed from oncology. So if you have a cancer, breast cancer is a very good example. There are very nice programs which will tell you when you start an adjuvant chemotherapy, you will reduce the risk by this and you have a response of this rate. This is very nice. And in IBD, we have now, as I told you, 30 different medications. And a lot of the younger people who are not working on a daily basis in this area, you get a little bit of problems, which is the best drug to start with, which is the best sequence. And this is just a lot of papers behind it. And then you could create, let's say, a decision support tool, which would help you to suggest this and this treatment is good. You should follow up this patient at this and this time. Do you think this is something for the future?
Two points I would like to reply with. First of all, what you describe is theoretically a non-brainer. But what we really need to do is upgrade our lousy databases. So the documentation of patients' data and images, if that's good or if that's perfect, then it can be translated into a perfect AI, what you describe. Number two with AI is something very different and quite boring, but very important to make our daily life much easier with all the documentation and administrative work and reimbursement. And so theoretically, if there was enough financial interest behind that, you could take a lot of unnecessary workload off the shoulders of doctors, also the young ones. So these are the two areas, perfect databases of our clinical work and get rid of the useless.
No, I think our work will become much, much easier. So for instance, if you record the discussion with the patient and you can make notes immediately, this is already standard in some clinics. And I think it will become standard in the next 5 years all over the world. So this is very good. Thomas, this was really a great discussion, and you put, as always, your finger into some of our wounds. And I think this stimulated also my future ideas, and I hope we can exchange in a year or two about the same topic, because I believe there will be a lot of changes. Thank you so much, Thomas.
Thank you. Great pleasure.